Okay, so now we're in chapter 62. We're going to talk about burns. Burn injuries are, really common. 500,000 people a year need medical attention because of some kind of burn. Not necessarily a severe burn, but, still. Most happen at home. Men are much more likely to experience a burn injury than women are. Very young, very old, of course, have increased mortality. Teaching prevention. Prevention is the best way to deal with, burns. Let's just prevent them. So, it's kind of a joke here in the South, but we're coming up on Thanksgiving. Every year we have somebody who gets burned in the ER because they fried a frozen turkey. Or they were trying to fry a turkey and they were drunk. That's just what you do in the South. You fry a turkey and you drink a lot. I don't know. So, burn injuries. And of course, at home, taking things in and out of the oven, in and out of the microwave, it spills. Kids run by the stove, grab a pot handle or hit a pot handle and it spills on them. Getting little kids getting in a bathtub and turning on the hot water. Just a lot of different things. So there's a lot of teaching, a lot of prevention strategies. Very easy to teach prevention. Very just simple things, simple techniques that will promote safety and prevent burns. All right, our goals, of course, I just talked about prevention. And then, in the case of a burn, life-saving measures for severe burns, they have, because of all of our new treatments and our prevention methods and our quick treatments immediately after injury, there is an increased outcome. They have better outcomes, increased quality of care, and less mortality. So instituting life-saving measures to improve quality of life, preventing disability and disfigurement through early care and specialized individualized care, rehab, reconstructive surgery. So it's not just, burns are long. It's a long-term recovery process, and each stage is very vital to help the person get back to the best quality of life that they can have. Some of our factors that are very important when we're talking about the severity of a burn, of course, the age of the patient. Again, the very young and the very old have worse outcomes. The depth of the burn, the total body surface area that is affected, how much of the body is involved. Were there any accompanying inhalation injuries? Inhalation injuries always complicate the situation. The location of the burn in terms of extremity, head, trunk, that kind of thing. And then if the patient had any other comorbid conditions to start with, if they had, asthma, COPD, heart problems, heart failure, renal failure, if they already have problems going in, then, what might not have been a severe burn under other circumstances can be very detrimental for that person. When we're trying to determine severity of the burn, it's classified according to the depth of the tissue destruction, and that tissue destruction directly depends on the causative agent, how hot the agent was, how long the agent was in contact with the skin, and then how thick that initial skin layer, the epidermis, how thick that skin is. Okay, so those are your factors that really affect the depth of tissue destruction. Causative agent, temperature of the agent, how long the agent was in contact with the skin, and the thickness of the skin. If you'll look on page 1808, it splits into these first, second, third, and fourth degree. The degree of burn or the degree of severity directly influence morbidity and mortality. So the greater the degree, the worse the outcome. So, I mean, you can see these here. They're pretty straightforward. First is superficial. Second degree is, epidermis and part of the dermis. Blister development. Some hair follicles are intact. Some are affected and some are still intact. So there is some hair. And if you think about the purpose of hair on your arms or on your body, then that should help you reason through why it's important if you have some hair in place and some not. Third degree burn, total destruction of the outer layer, excuse me, the epidermis, dermis, and the underlying tissue, which would be your nerves mostly. Third degree burns are painless because all of the nerves are involved. So patients with third degree burn a lot of times they don't even realize how badly they're burned because they don't feel it. First and second degree burns are painful. The nerves are intact, and many times the patient is in a lot of pain, especially with second degree. They're in a lot of pain. Third, fourth degree burns do not involve any pain because there's destruction of the nerve endings. The fourth degree is very deep. It's a deep burn injury with involvement of not just skin, layers and tissue, but muscle, sometimes bone. So it is a very deep type of a burn. When we're estimating the body surface or the extent of the body surface that's involved, there are some basic rules that out-of-hospital providers, EMS, fire department will use. These are discussed in your book, starting on page 1809. The rule of nines is probably the quickest and the most common for adults, and that just basically says that each of the body parts or body sections are divided up into multiples of 9 to equal out the body surface. So the trunk, for instance, the front of the trunk is 18%. The back of the trunk is 18%. The head is 9%. Each arm is 9%, and each leg is 18%. Altogether, its total body surface are 100%, I think. I haven't done the math, but so it's a quick estimate. If they are, if the head, one arm, and part of the trunk, the front part of the trunk is involved, then you would do 9, 9, and if it's only half of the anterior surface, you could do 9. If it's the whole anterior trunk surface, then it would be 18. So you can see how you can estimate this very quickly. And of course, again, the greater the body surface area involved, the worse the outcome for the patient. A second method is called the Lund-Browder method, where it looks at the percent of surface area, of individual anatomic parts in relation to the patient's age. It's a little more precise, but it takes a little bit more to calculate. So again, it can be used for larger surface areas. That's why rule of nines is so easy, because you can, for patients who have a large extent burned, it's easy to figure up, or estimate the percent. The Lund-Browder method can be used, it's pretty accurate, and it can be used for larger body surface areas as well. It's more precise than the rule of nines, and it's more specific because it's related to the patient's age. And then the Palmer method is used for smaller area burns, scattered burns, and roughly the way that works is that you would estimate the size of the patient's hand is about 1% of their body surface area. So, you know, if they've got scattered places over a trunk or over a leg or an extremity, then you could say, okay, for each spot, if it's about the size of the patient's hand, then you count 1%, 2%, 3%, and so forth. So rule of nines is probably what you're going to see most, I guess, especially if you're working in the ER, and then the Palmer method. Okay. All right, so just a little background, a little physiology about burns in particular. Physiologic changes, of course, they're caused by a transfer of energy from whatever the heat source is to the body, and it leads to disruption of skin layers, so which that leads to, of course, fluid shifting, fluid loss, infection risk, and heat loss, hypothermia. Okay, even though the patient has been burned by something that's hot, once that heat source is removed, eventually the temperature is going to start, the body temperature is going to start to drop. And when we don't have our intact skin, mucous membranes, hair follicles, then we lose our ability to regulate. If the burn is less than 20% of the body surface area, it typically will only generate a localized type response. So we'll talk about those responses in just a minute, but if it's less than 20%, it's typically a very localized response. If the body surface area involved is greater than 20% body surface area, then it's going to not just generate a local response, meaning a inflammatory type response, but it's going to be systemic also. Okay, so greater than 20% body surface area is considered a major burn injury. These responses, again, they're inflammatory in nature because there's a release of cytokines and those other mediators, and it just sends them into circulation, and it causes fluid shifting and hypoperfusion. So it can lead to a shock state very, very quickly. Okay. Some of the physiologic changes that are involved with the burn area or burn injuries, systemic, like I said, and local responses. It creates a change in blood flow, elimination of those protective layers, changes in blood flow, causes tissue edema, and exposure for infection. When there's destruction of blood vessels or even just altered blood flow, okay, hypoperfusion, poor circulation, organ hypoperfusion initially because there's decreased cardiac output, and so there's underperfusion of those organs, which can lead to shock, and that combined with massive fluid shifting can also lead to shock. Eventually, the patient will go into a hypermetabolic state, but initially they're going to have decreased perfusion. Okay, they're going to be hemodynamically unstable because they have no capillary integrity. They don't have any ability to regulate fluid shifting and electrolyte shifts. Okay, so the patient's going to become edematous, severe edema very quickly with a burn because they don't have the ability to regulate fluid shift, interstitial fluid shifting. They have no capillary integrity. It's typically from damage. So severe edema very quickly. All right, some of the physiologic effects that we see with major burn injuries, cardiovascular changes initially from the hypovolemia, so it causes a decrease in blood pressure a decrease in the mean arterial pressure, and of course that leads to changes in cardiac output, systemic hypoperfusion, which can affect other organs. There is massive, massive, massive fluid shifting, like I said earlier, from the burn itself. It causes severe edema, third spacing. So it's a relative hypovolemia that can lead to what's called burn shock, which is a type of circulatory shock. And then electrolyte shifting, low sodium and high potassium initially, and then later on the patient will start to lose potassium too. So there's going to be that risk of electrolyte or a dysrhythmia from electrolyte disturbance. Pulmonary injury, upper and lower airways problems. The pulmonary injury may not be obvious or readily apparent at first. The initial assessment may not show any damage, but depending on the circumstances of the injury, there can be airway edema that develops later on. It can take up to 12 hours for there to be significant airway edema develop, but it will usually with an inhalation injury, airway edema will develop, and then that either alters ventilation and or perfusion. So there is a real risk that the patient will develop respiratory distress, respiratory failure. ARDS is common. So it's very important to do a very thorough respiratory assessment. Upper airway, generally upper airway injury is from direct inhalation of high temperatures of air, or gases that are greater than 300 degrees. And that causes a burn, a direct burn to the upper airway, and that causes edema. And eventually the edema leads to airway obstruction. So early intubation is the treatment if there's an upper airway or a suspected inhalation injury. For inhalation or consideration below the glottis, that's typically from breathing in gases during from smoke. That also will lead to edema. It can damage the cilia in the airway, so there's a loss of ciliary function. There can be bronchospasm. It can lead to atelectasis. So you can see that that would progress into respiratory failure. Can be the result of carbon monoxide poisoning, and then with the edema and the shifting and the bronchoconstriction, then it can turn into a restrictive problem. It can actually reduce the compliance of the lungs. So inhalation injuries can be, even though they're not readily apparent, anytime there's a suspected inhalation injury, the patient should be intubated. So you should always anticipate intubation. Can be issues with, renal impairment from decreased mean arterial pressure, which would lead to decreased perfusion. And then there's also the problem of free hemoglobin in the blood, and then if there's muscle damage, then you have myoglobin, and so that can lead to rhabdomyolysis, where the myoglobinemia, actually, where that myoglobin, the kidneys try to filter it out, tries to because there's just a massive amount of it released into circulation, and the kidneys try to filter it, but the myoglobin actually kind of clogs up the kidneys, and that combined with the hypoperfusion can put the patient into acute renal failure. GI alterations that are common are from the loss of capillary permeability or capillary integrity, and it allows bacteria that are in the gut to leak out, And so there is a very real risk of sepsis in these patients because they don't have that good capillary integrity to keep everything where it belongs. And then because the gut is always the first thing that loses circulation, when all of this shifting and shunting happens, and the mean and the blood pressure fall, blood's going to be shunted toward vital organs, and the gut is going to not get perfused well. So there's a risk of ileus. That's common. Immunologic alterations, I just said there's a high risk of infection and sepsis, and that can come directly from that GI disruption. And then also the loss of our protective skin layer. That's the body's first line of defense. So with that gone, that puts us at risk for infection. And then the patient is also immunosuppressed to a certain extent because they have lost all of these protective mechanisms, and so they are exposed or at greater risk of developing or contracting an infection. And then the last major effect is on the body's ability to maintain temperature. We lose, the patient loses their ability to regulate their body temp, and it's multifactorial. I've already kind of talked about all of that, about the loss of the skin layer and the fluid shifting and things like that. But initially they're going to manifest a low body temperature. There's going to be heat loss from loss of those protective functions. And then eventually the patient transitions into a hypermetabolic state. And that is the result of having a sustained increased core temperature. It actually, when the patient is exposed to high temperatures, as in a burn, it actually leads to resetting of the core temp because their body temperature, their core temperature, will eventually stay elevated. So they'll reset to where their normal may not be 98.6, it might be 99. That might be a normal baseline temp or a reset temperature for them. So initially body temp is low because of the loss of those protective mechanisms. And then over time the body actually adapts or adjusts to that elevated core temp. And there's a lot of it has to do with hypermetabolism. It's as the body is trying to compensate for everything going on, there's this hypermetabolic state leads to a sustained increased core temperature, and then the body actually resets. Management strategies, if you'll look on page 1814 in your book, there's really 3 phases: the emergent or resuscitative phase, acute or intermediate, and then the rehab phase. Okay, so we're going to talk a little bit about each of these, how these stages. Well, emergent or the resuscitative phase is defined as from the onset of the injury until completion of fluid resuscitation, whenever that time frame is. And then that acute intermediate phase is from the beginning of diuresis to wound closure. And then the rehab phase is from wound closure to getting them back to the best state that we can after their injury, getting them back to optimal physical and psychosocial function. Okay, the emergent resuscitative phase is usually what we call on the scene or out of hospital. This is the immediate time right after the injury. So our focus here is, as far as the main priority at the scene of the accident is to prevent injury to the rescuer, put out the flames, cool the burn, irrigate it if necessary. If it's a chemical burn, you want to go ahead and irrigate or flush. And then we're looking at ABCs. You got to make sure that the patient has a patent airway, adequate breathing, adequate circulation, and of course plan, depending on the type of injury. If there's inhalation injury, you've got to plan for protecting the airway. During this time, they're going to put the patient on oxygen once the scene is safe. You know, once it's not a fire hazard, get them on oxygen as quickly as possible. Get the patient to a safe location. Start 2 large bore IVs, because remember, we're anticipating massive fluid shifting, so we've got to have circulatory support ready. They're going to be getting any clothes or anything off of the patient that are restrictive or that might still be contributing to the burn. And then, and again, you have to remember things like jewelry, bracelets, necklaces, things like that, because the fluid shifting is going to happen very quickly. And as that edema develops, things like rings and watches and necklaces, they can be very restrictive in nature. So you have to really look at that kind of stuff. Covering the wound, if there's anything that's exposed, then it will be covered with a saline-soaked sterile dressing, and it has to be sterile, because remember, we have that loss of protective layer, and we don't want to expose the patient to infection. Very rapid assessment of all body systems. Try to get as much of a history as possible about the accident, and get as much information from the patient as you can at this point, because it's likely that the patient is still awake. Even if it's a severe injury, they're likely still awake and able to talk to you. So this is a point in time where you really want to get as much information as you can. And then, just taking note of what kind of injury is involved. Was there a fall, or do we need to be looking at cervical spine stabilization? Was it an electrical injury? Just specifics about what happened. Also during this time, the patient's going to be sent, of course, to the ER. Fluid resuscitation is started immediately. That's what the IVs are for. They're going to put a Foley in. Patients that have a burn, a major burn, greater than 20 to 25% of their body should have an NG tube put in. They're going to immediately, decompress the stomach and try to prevent any of that GI content or bacteria from, transposing, leaking out to lead to sepsis. They're working to stabilize the patient, continuous monitoring, especially if it's an electrical burn, you've got to be looking at EKG, because there can be some dysrhythmia there. Pain medicine is essential. Definitely no oral stuff. We're keeping them NPO. But addressing pain and addressing all the psychosocial issues, emotional support during this critical initial time. Okay, it's going to be a lot of confusion, a lot of high anxiety, questions, concerns, and so, good, straightforward, not, this is not the time to be talking to them about how severe things are, but it's the time to give good emotional support and, psychosocial support as much as possible. During this phase, some of the fluid shifting that's going on, again, this is massive third spacing edema, so you're going to see signs of just generalized dehydration, reduction in blood volume, hemoconcentration. That's where we get the elevated potassium. decrease to no urine output. The massive trauma releases potassium into the extracellular fluid again, so that contributes to hyperkalemia. And as that potassium is released, then that causes the shifting of sodium, and so they end up with low sodium. So you've got risk of dysrhythmia from all of this electrolyte dysfunction, leads to a metabolic acidosis. The patient, and that's if they don't have inhalation injury, but they still can become very metabolic in nature. Fluid resuscitation is essential if the patient's going to survive. 2 to 4 liters per kilogram per percent of body surface area burned in the first 24 hours is considered adequate. So, 2 to 4 liters per kilogram per percent of body surface area that's involved. That's the amount of fluid resuscitation that is required to try to keep the patient stable. During the acute intermediate phase, this is anywhere from 48 to 72 hours post-burn, post-injury. So we are continuing our respiratory and circulatory support, very thorough assessment, watching the airway, monitoring for edema development, especially with inhalation injury. It can take up to 48 hours post-burn for inhalation injuries to develop. So, sometimes 12, but up to as long as 48 hours. So watching the airway is essential. Infection prevention, wound care, keeping the wound clean, and they're going to start trying to debride the wound bed as quick as possible. There's a risk of pneumonia. The greatest risk of pneumonia in a burn patient actually comes from them being intubated. But, unfortunately, if there's an inhalation injury, we don't have any option other than to intubate them. So diligent oral care, diligent, aseptic technique when we're doing suctioning and dealing with the airway, things like that. Pain management. If it's not a 3rd or 4th degree burn, then they're going to need a lot of pain meds and nutritional support. They need increased calories for healing, but may not be able to use the gut. So you have to kind of think about what are we doing in terms of nutrition. And then, as I talked about before, fever, the resetting of the core temp occurs at this stage. They're going to stay, when they reset, that's essentially saying they have a new baseline body temperature, okay? And it's going to stay a few degrees higher for a while. Even after they get better and they heal, that baseline core temp is going to stay elevated for a while after the burn. And then if they have problems with sepsis or bacteremia, that can be another source of fever. So, I told you before that a lot of times it comes from leakage of the normal flora from the gut, as well as from outside sources because they have loss of protective mechanisms. So you have to really assess for fever during this stage. Fluid and electrolyte shifts at this point. Initially there's that loss of capillary integrity in that initial stage. Well, during the acute phase, intermediate phase, we see a little bit of return of capillary integrity. So fluids start to shift back into the vascular space from the interstitial space, and so they end up getting very hemodiluted where they had been hemoconcentrated before. When all this fluid begins to shift back, they become hemodiluted or overloaded almost. So there's electrolyte changes that take place. That's where your potassium levels can get very low from dilution. Diuresis results because of all of this hemodilution. The body's natural response is to pee it all off. So hopefully the kidneys are still intact. Hopefully they haven't been traumatized from low blood pressure or damage. So hopefully we're able, the patient is able to diurese all of the excess fluid. But there is a very real risk of volume overload at this point, as well as electrolyte imbalances. So your assessments are still very close and essential. This would really is where you would have to take into effect in an older person if they have a history of CHF, or if they have a history of COPD, or if they have renal impairment to begin with. You really have to assess, make sure that their kidneys can handle the amount of fluid that's shifting back into the vascular space. Infection prevention. Of course, I said sepsis is a major cause of death. It's a major problem during the intermediate stage. MRSA, VRE, E. coli, staph, enterococci, yeast, those are all very common culprits. We have no skin protective ability. Of course, all that burn tissue is a medium for bacterial growth. eScar is the scar tissue that develops, the blackened, dead tissue. It has absolutely no blood supply, no vascular supply at all. So it doesn't matter how many antibiotics or, it doesn't matter what we give the patient. It's not going to get in the eScar because it has no blood supply. So that has to be debrided. We've talked about the GI tract and translocation of bacteria, strict infection control measures, transmission-based precautions. These people face long hospital stays. They are months and months and months in the hospital. They have a lot of invasive procedures. They are immunosuppressed for various reasons. And so all of these things contribute to an increased risk of infection. So strict aseptic technique is essential. That's why the burn units are so strict. So you just have to be constantly thinking about infection prevention and prevention of sepsis and signs of sepsis. All right, wound cleaning. When we talk about debriding or getting rid of anything that's dead or non-viable, that's the goal, is to remove non-viable tissue. And then also part of wound cleaning is to remove if there were any agents or healing methods that they had put on the wound. We use wound cleaning as a process to remove the old product and so that we can put on new. Okay, so some of our wound cleaning methods: hydrotherapy, water therapy, shower, mobile showers, putting a patient, a lot of times they'll be on a stretcher and they're equipped to put the whole stretcher in there. Okay, we never soak these patients in a bathtub. You would never do that because that promotes a risk of infection. Have to be very cautious about hydrotherapy because when they're wet, there's that risk of hypothermia, and then it hurts. Pain management. from the water hitting that fresh skin. So definitely wanting to give them pain meds before they go. And you know, a lot of times when they're in the shower, they'll do a lot of actual mechanical debridement, scrubbing, or trying to remove some of that dead tissue, and it is very, very painful. So liberal use of pain medication during this time. Topical agents, if you'll look on page 1822, there is a discussion about all the different topical agents. The most common is probably Silvadene, silver nitrate. Those are agents. Sulfamylon, those are all agents that are used topically to help protect and promote wound healing. Wound dressings and dressing changes, you know, that's going to be done depending on where the wound is and the extent of it. Of course, we always keep, you know, sterile dressing, keep it covered, but those dressing changes are done as frequently as they need to be, but not so much that we're exposing to the risk of infection. The goal is, the point is to change it when it's dirty. So if it's weeping, if the wound is weeping or bleeding, you know, then they will change it as frequently as necessary. Wound debridement is aimed at removing the old, dead, devitalized tissue and leaving it, you know, clean so that new tissue can begin to form. Okay, well, that can be done. You know, there's natural methods, mechanical methods, and then surgical methods. So our natural debridement is aimed at proteolytic processes where we can get the eschar to separate from viable tissue. Okay, and there are some substances, some natural proteolytic, enzymatic type substances that will be used for that. Mechanical debridement just means we're removing the dead tissue with scissors, you know, forceps early on. Okay, just trying to get all that dead tissue off of there. And then surgical debridement means, you know, going to the OR, just surgically excising non-viable tissue down to the viable tissue. They'll actually go in and they'll cut down until they have really good bleeding tissue. That's the good healthy stuff. If it's bleeding, it's healthy. That's the thing about burns. If it's dead, that eschar has no vascular support, so it won't bleed. Surgical debridement needs to be done early on. The earlier surgical debridement is done, especially if we can debride it and get some good wound closure, then that's going to improve the patient's survival rate. Other, you know, things that you're going to see in terms of wound cleaning, they're going to, you know, of course, keep the patient's hair cut short, hair clipped, try to remove anything that's loose. You know, any loose or non-viable tissue should be removed. Blisters should always be left alone because that's a natural covering. Leave them intact. Even with a simple burn at home, if you know, touch the oven or something and it blisters, you should always leave those alone because that's the body's natural covering. So they don't ever, you know, try not to mess with any blisters. They'll leave those alone. And then eventually they might do some skin grafting, which we're going to kind of get into a little bit of detail about that in just a minute. But the point is to get the wound bed down to good viable tissue so that it can begin to heal and grow. Wound grafting, basic types of wound grafting, autografts, homografts, and the biosynthetics. Okay? Autograft is basically a biologic. It's the preferred method. It can be the patient's own skin tissue from another area of the body that wasn't burned. It can be a donor graft, from, and we talked about brain death, we talked about end-of-life issues in a previous lecture, and organ donation, and a lot of times, that is skin or tissue, and that's what it's for. It's for burn patients. So, of course, if it's a donor graft, there is the chance of rejection. If it's a patient's own skin graft, of course, there is no, rejection there, but make sure you look in the book about the specifics of graft site care related to grafting. Our homografts or xenografts are biologic also in nature. These are used for temporary wound coverage. They are not a permanent skin graft at all, but they promote granulation of healthy tissue. So these are the ones, the xenografts, homografts, same thing. That's your initial or your temporary mechanism that's going to be used as the patient's wound granulates, and they'll use these until they can do an autograft. Homografts are expensive. They are the most expensive, but they have the best outcome. So, if you go into a burn unit or something like that, then you might see stuff like this. The biosynthetics or synthetic dressings, these are probably the most commonly used. They are a synthetic material. Again, they're used in an interim until an autograft, till it's time to do a permanent autograft. But with the biosynthetic and synthetic dressings, it's cheaper. It's synthetic. So it's a good way to cover the wound and promote healing. They last longer. They can be put on and left in place. They don't have to be changed as often. So that also contributes to the cost. And they work well. They're not. It's not like it's second best. It's just not biologic tissue. They're synthetic, but they are cheaper. They're more commonly used, and they do promote good healing. All right, pain management. Burn pain is one of the worst kinds of pains that a patient can ever experience. It is one of the most severe forms of acute pain. So pain management is essential. And it's not just episodic. A lot of times they have a continuous type of pain. So, and they have pain, because they're injured. They have pain during their treatments, wound care, cleaning, dressing changes, debridements. They've got different types of pain. Okay? So that background pain, just the continuous level, it's almost like a baseline pain, even when they're not active, even when they're laying still, because their nerve endings are damaged. So, here you would want some sort of long-acting analgesic to try to help control or keep it at bay. Procedural pains, or procedural pain related to, like I said, debriding, wound cleaning, dressing changes. So, in those situations, the patient needs to be medicated before, in a timely manner before the treatment. And then They will have breakthrough pain. You know, they've got this underlying baseline or background pain all the time, and then they'll have these episodes of very intense, episodic pain, sometimes related to movement, sometimes not, but you know, they'll have this breakthrough pain. So our pain management has to be tailored specifically to the patient and what's going on with them. You know, first and second degree burns, superficial burns, have exposed nerve endings. You know, if you remember, I talked about third and fourth degree where the nerve endings are destroyed, and so there's no pain there. But with second degree especially, the nerve endings are exposed. So these burns are very painful. Movement, even things like temperature change, airflow, pressure on the area can be excruciatingly painful. All right, some of the things we're going to be using for pain management, of course, analgesics, opioids, morphine, fentanyl, very common. Not unusual for the patient to have a PCA if the patient is awake enough or you know, able to utilize the button on their own. Patient-controlled analgesia is an excellent option here. Some of the other medications that are commonly used would be NSAIDs to help reduce inflammation, anxiolytics, benzodiazepines to help not just with pain but to reduce anxiety as well, to help keep the patient calm. And then in situations where you know, if there's intense wound care or dressing changes, then we, you know, could be doing moderate sedation or actually doing a surgical, you know, using general anesthesia for a surgical debridement. Or, you know, I've even seen patients just to have wound care. You know, if they have a burn that's a large extent of their body or a big, you know, deep area, severe burn, then, you know, they'll just do it under general anesthesia because it's so painful. You know, anxiety plays a major role in making pain worse, and it also can really affect the patient's ability to rest. You know, they may just not be able to be comfortable, and we know the effect of sleep deprivation on healing and mental status. So, you know, it is essential that we try to control the patient's pain as much as possible. We may not be able to get them pain-free, but we certainly need to do our best to try to keep it at least at a manageable point for the patient. Non-pharmacologic methods are very important. Distraction, relaxation, guided imagery, humor, just anything where we can get the patient focused on something other than the amount of pain that they're experiencing is going to play a major role in their healing process. All right, let's talk a little bit about the hypermetabolism that happens because, you know, burn injuries do lead to profound hypermetabolism. It's a profound metabolic abnormality related to the stress response. Okay, so again, it's a hypermetabolic state from the increased body temperature. It can actually lead to a catabolic state if if the wound is not handled or dealt with appropriately, then the body will actually begin to break itself down, catabolize itself. So getting rid of that eschar, getting rid of non-viable tissue is the best treatment to prevent an increased metabolic rate. Early enteral feedings also help to promote wound healing, and it also helps to promote the integrity or maintain the integrity of the gut. But we have to make sure that the patient can tolerate enteral feedings. So, you know, you have to really assess for ileus. You have to assess for gut integrity and watch for sepsis. This would be a time where you would really check residuals for tube feedings and things like that, making sure that there's adequate motility, because you definitely wouldn't want the patient to aspirate. You know, and then you have to, of course, like I said, be on the lookout for sepsis. Enteral route is preferred. The jejunal feeding, which is where they pass the feeding tube down into the small intestine, is can be more frequently seen because the patient can actually receive nutrition that way with a lower risk of aspiration. So, enteral, jejunal, either one, they still help to maintain the gut integrity. Our nursing management is aimed at restoring fluid balance. We want to prevent fluid overload, also to prevent dehydration. So we're doing daily weights, we're watching urine output, looking for signs of edema, just our basic management of fluid balance, infection prevention, aseptic technique, contact precautions, keeping that wound covered appropriately, adequate nutrition, increasing protein and calories for healing, giving appropriate vitamin supplements, oral fluids if indicated, promoting skin integrity by good wound care, doing dressing changes appropriately, monitoring and assessing pain, frequent pain assessment, given medicines as ordered, frequent medication administration, our other non-pharmacologic measures, physical mobility problems or our interventions aimed here is DVT prevention, contracture prevention. These people might be bed-bound for a while, so we have to make sure that, if their backside is not involved in the burn injury, then we have to really make sure and prevent skin breakdown, DVTs, contractures, that kind of stuff. And then, of course, the psychosocial, coping with depression, anger, fear. There's just a lot of emotion that happens coping and family support in a burn situation because, it's just multifactorial. There's just a lot going on, and so our psychosocial support is essential. Of course, potential complications of a burn injury, respiratory failure, ARDS, heart failure from fluid overload. Greatest risk of respiratory failure and heart failure in patients with existing renal disease, or if they end up in acute renal failure from the burn injury, then of course they have greater risk of respiratory problems and heart failure. Sepsis, from infections, so our big focus is to assess and prevent septic shock, circulatory shock. Assessment of the respiratory system, just staying on top of stuff, anticipating problems, and then acting quickly at the first sign that something is not right. Okay, the last phase is the rehab phase, rehabilitation. The rehab, really we began looking at rehab immediately, okay? You know, we say this all the time in general about any patient. We begin discharge planning the moment they get admitted, because ultimately we want them to go home. Now, we don't know how long that's going to take to get them there, but we want them to go back to whatever quality of life they had before. That's the goal. So really our rehabilitation phase is begun immediately, and then it extends for as long as necessary, you know, as long as we need it to extend after the injury. Our focuses here are, of course, wound healing, but psychosocial support, dealing with depression, post-traumatic stress disorder is very common after a major burn. Self-image, you know, trying to get them back to maximum functioning, the greatest level of functioning that they can have, best quality of life that they can have based on the injuries that they sustained. So, you know, we have to really begin looking at steps to get them back to that point. They might be looking at, you know, needing some kind of reconstructive surgery or long-term therapy, rehab therapy, to help them learn how to function or walk or use their hands, or, you know, do the basic ADLs. So, you know, our focus in the rehab phase is to increase their mobility and ambulation and their ability to perform ADLs and self-care. We're looking at, you know, teaching them how to take care of their wound eventually, or, you know, scar management, and get back to work or go back to school. So, you know, eventually we might be looking at job counseling, vocational training, support groups, things like that, just to try to get them back to a quality of life. We may never get them back to where they were pre-injury, but we can help them learn to have the best quality of life they can with